So there are two different schools of thought that each person and each patient has to take into consideration when considering surgery. So there are some patients who want to do everything they can to avoid surgery, and that's fine. Again, there's no harm coming to the patient not having surgery. And typically, as a physician or orthopedic surgeon, I'll encourage younger patients to do everything possible that they can to put it off. But again, you want to enjoy life as well. So, there comes a balance there when it's impacting your ability to play with your kids or do your work or just go for a simple walk with your family or do some moderate exercise. There comes a role when quality of life becomes an issue. But in younger patients, as a rule, we try to do more, try to maximize our non-operative treatments. On the other hand, as time goes by and we get older, some patients then, as we get older in their 70s or 80s, and they're becoming limited and they're not having the quality of life that they want and they're having trouble sleeping, as opposed to continuing to string this along where they're not happy and miserable, those patients may wish to have surgery sooner as opposed to try to delay things for the inevitable for a few months. Some of those patients may wish to just have the surgery and have the best chance of feeling better. Following knee replacement, the recuperative course after knee replacement, somebody has to be cognizant and motivated to do the rehab that's required. So, that's really the key focus in any surgery with orthopedics is patients have to be motivated to do the work and to do the therapy. When someone has an arthritic knee, sometimes we have more options and treatments of arthritic knee than just a knee replacement from a surgical standpoint. Sometimes there can be something called an osteotomy. If there's just one area of the bone that's involved with arthritis, sometimes we can make a controlled fracture of the leg to redistribute the forces to lessen the stress off of that area. The recovery can be longer with that as the bone has to heal. The pain is typically less completely relieved, and it's typically a bridge to a knee replacement. So that may be something we consider more in a younger person in their 30s or 40s before we start talking about a knee replacement. Also, sometimes partial knee replacement is a possibility when there's just one area of the knee where the arthritis is. It's not diffusely spread through the knee, and that may be something that a certain percentage of patients have a role for as well. I think personally in my practice it's a small percentage of patients, but there are patients who are candidates for these surgeries. Similarly with hip replacements, it used to be managing hip pain was take a couple aspirin and Advil and call me in 5 years when you can't deal with it anymore. But over the last 10 years or more, we've recognized some more pre-arthritic conditions called femoral acetabular impingement, where we recognize that the ball is somewhat out of round, so it's sort of like a square peg fitting into a round hole, which can lead to early arthritis or problems with the labrum. And sometimes we can do procedures to reshape the ball, whether it be arthroscopically or an open procedure, or do things to help address problems with the labrum that we weren't able to do 10 or more years ago. So there are more options as time has gone by to lead up to hip replacement or knee replacement, but ultimately the gold standard for treatment of arthritis of the hip and knee from a surgical standpoint is a hip or knee replacement.